are pleased to welcome our next speaker, Dr. Ashok Kumar Rohilla. Dr. Ashok Kumar Rohilla is working as a consultant endocrinologist, CEDAR, Clinics, Panipat. He has many publications in reputed journals. He is contributing author of Guidelines of Indian Standard of Care for Gender Incognate Children and Adolescents. He received gold medal for oral presentation in Pituitary Endo updated in 2017. He is a life member of Endocrine Society of India, IPAD, IMA, IPATH, and ICBMR. Sir will be delivering the session on non-endocrine intervention for gender affirmation. So I welcome sir. Now I would like to invite our next speaker. She is Dr. Pramila Kalra. Dr. Pramila Kalra has done her MBBS from King George Medical College, Lucknow. She also done MD from King George Medical College, Lucknow. She has done her DM in Endocrinology from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She has 68 scientific publications in national and international journals and 23 chapters in various books. She won A.V. Gandhi Award for Excellence in Endocrinology for the year 2008. She is an executive member of KRSSDI for the year 2011 and 2012. She is an executive member of Indian Thyroid Society. So I welcome ma'am. And she will be delivering the lecture on endocrine management in childhood and adolescence with the Dr. Mohan Shenoy. I welcome ma'am. We are having our third speaker with us, Dr. Mohan Shenoy. Dr. Mohan Shenoy is an alumnus of one of the earliest government institutes in India, namely Trivandrum Medical College. He is an experienced data manager with a demonstrated history of working in the hospital and healthcare industry. He is skilled in research, diabetes, clinical research, epidemiology, and data analysis. With strong information technology focused on pediatric endocrine practice. He is a member of editorial board in Indian Journal of Child Health. I welcome sir, and he will be delivering the session on endocrine management in childhood and adolescence, along with Dr. Mohan Shenoy and Dr. Sujas.
So, very good afternoon, everybody. We have learned about the hormonal management in the trans man and trans woman from the Dr. Devmala and Dr. Suja. Now the next segment of the hormonal management of the transgender that is left is the management in children and adolescents. After covering that topic, we will be discussing about the non-hormonal interventions in the care of the trans man. See, what I see my branch endocrine, like some 15-20 years back, there was a lot of gray zone in this branch. And the same thing which I am saying when we come to the transgender care, the segment or the domain of the transgender care which is more defined, and though there are a lot of gray zone in this segment, this domain also, which is endocrine. Dr. Devmala in his talk highlighted that the satisfaction rate is almost 90% in trans person with the hormone therapy. I think that level of the satisfaction we need to attain in the other domains also, but we will be particularly touching on the hormonal and the metabolic aspect of the transgender care. Now I'll hand over the mic and stage to ma'am and Dr. Mohan. Thank you.
Till we actually start, I just wanted to set the ball rolling. So I wanted to just set the background to a discussion. So non-endocrine interventions are a lot of non-hormonal interventions as such. So these include so many other things. So I would just like to know from Dr. Ashok regarding the extent to which we have to understand about this topic. What is the backdrop of this discussion?
So the background is that, see, the care of the transgender is not limited to the management of the hormonal aspect or to the surgical aspect. One learned audience from the back asked about whether we can proceed with the surgery before start of the hormone therapy. Well, I think it's a slow process. I think we should give time to the person to think about and to imbibe the idea which is in his, like what he's thinking about what is the understanding of that person, subjective understanding of that person is about his or her sex. So that is one aspect. Now coming to the metabolic aspect, beyond the hormonal care, we need to look into the lifestyle modifications, that is the metabolic, because what we see, the metabolic issues are more in the trans person, be it diabetes, hypertension, dyslipidemia, and these are aggravated by the hormone therapy and the other therapy medication which are given for the care to attain the desired results. Now the another aspect is the surgical aspect, then the speech therapy, and there are many other aspects. I think we can finish the rest of the talk after we finish that.
Yeah. So good afternoon everyone, and we'll be discussing a little bit about the endocrine management in adolescence and childhood, and that's even more controversial because we still have some clarity on few issues and some issues needs to be discussed. So we'll start off with one of the case scenarios which we commonly see in our OPD setup nowadays, and then we move on that how we can go best with it and how we can best deal with the situation. Now this is a child who is 11 years old boy who is brought by her parents, I will say, as they were concerned that the child was dressing up with her in her sister's clothes, and the child wanted to behave like a female and was more comfortable with girls, playing with the girls' toys, and the child was brought to the endocrinologist. The parents were worried about it. They had gone to the counselor, but they were worried about it, and they wanted some treatment. But what they had come for was, and what we commonly see in our practice scenario, that they wanted the endocrinologist to start some hormones so that this thing doesn't happen. So they were not supportive, and this is still a common scenario, like Dr. Devamale also said, and we deal with a lot of adult gender incongruence, and we do see that the family support system has become better over a period of years. In the past 12 years of my practice with gender incongruence, I would say that it has become much better, but still it is not up to the mark, and especially for kids, the parents don't sometimes agree to it, and we know that some of them may be persisters, some of them may be desisters, so they may persist, they may not persist, but we need to have approach to that how best we deal. So with this thing in background, I asked Dr. Mohan to comment that how do we proceed further with such a case scenario, because this is a common case scenario we all see in our OPD setups.
Thank you, team, for having us here. So before we go further, we should know what, because we are dealing with. So gender is a concept which has been described in ancient literature, medical literature, as well as the social fabric. So as you can see in this picture, the way the child perceives is what actually reflects in that diagram. You can see the stepping stone of the first is gender identification. So we should always ask, just like the previous Emerson had commented, so how that person perceives the gender, it actually takes time to build up. So maybe we should not be having a binary concept in an initial pathway, but we know our syllabus on school, definitely, and even the birth certificate, I am glad we have got efforts to collaborate on that as well. So we can see here that another concept is that gender recognition. So the way the person perceives that can actually start very early, but it can actually recognize, can be actually continued, and the growing years it becomes confirmatory. So I was part of the working group which published the guidelines along with Dr. Sanjay Kalra, Dr. Sanjeev Kumar, Dr. Ashok Rohilla, and Satyavani, Dr. Vinita. So we have a team of doctors with ethical experts also, which framed the first Indian guidelines which came into public domain about 2 years back. And in this, the idea is about a team concept. So it's not an individual's choice as such. We have to have a team which works around that choice. And you can see this graphic that the child is in the center of everything. So child actually tells us what the person perceives. The family builds through that. then the team works with it. The team includes psychologists, the other experts, mental health experts. They have also included other school people, the nurses. So many people are there and stakeholders. Don't forget the community also, because the law has also been changed as we went along. So previous guidelines did not have the reflection of the latest transgender rules which had come, but in pediatrics we don't call them as transgender, we call it gender dysphoria. So that's what the Dr. Pramila's case had reflected. So team is the person deals with it, pediatrician works with endocrine expert, and endocrine experts work together with the psychologist. So we together come together for this concept. So that is how they go through it. So with this, actually, we have to understand with the other terminologies. So I wanted to know from Dr. Pramila Kalra, ma'am, what are the other terminology which we are going through this?
Yeah, Dr. Mohan. So that is what, because this is quite a common thing which is asked. A lot of people ask that what are the terminologies, what is gender identity, then what is the gender expression, then what is the gender assigned at birth. So when we talk about the gender, we know that there is a particular gender which is assigned at birth. When the child is born, the parents are told that a girl is born or a boy is born. We know that we have ambiguous genitalia and we have disorders of sexual differentiation. Those are another set of things. But overall, they are told either the boy or a girl is born. And then over a period of time, the child recognizes themselves as a boy or a girl. So that is what they think that they are. And that is how the patient identifies themselves or the person identifies themselves. And then they express, like some people may identify themselves, they may express like that, they may not express. That also depends on a lot of other factors as well, even the societal factors and many other factors. So when we talk about these, this is how we say, the gender identity is a person's internal sense of his or her own gender. So what the person feels. Now it may not be necessary that that person may behave or may come out like that. They may think like that, they may be feeling, they may not come out with that. That is a person's decision. Then gender expression is the one which is the external manifestation of one's gender expressed through the clothing or the behavior or the body language or how they behave or how they exhibit their things in the society as a perception of gender to others by way of the play or by preferences for toys, and that is what we say as the expression of that gender. And then we come to the perception. Now perception is objective perception of the gender expression, that is the way others interpret it. That is the perception. And the gender incongruence or the dysphoria, what we say, is when the distress is caused. This distress may be less, maybe extreme distress, which is caused by the mismatch between the one's gender identity, that means a person's internal sense, and what is the gender designated, or we can say forced upon that person. Because many a times we know that the incongruence is there and the society is not supportive, the family is not supportive, and because of that there is more of dysphoria which happens. So with this we come to another new concept, which is the gender fostering. So I would like Dr. Mohan to comment on this.
So gender fostering is a terminology which is actually happening for the last 2-3 years, and there are some things which the child goes through, because in that process of building trust with the parents, the community, the love, so many things happen through the next few years which that person goes through. So I think by the age of 8 to 9 years the person will identify most of the often, but beyond that also we have had puberty people, some children come and identify themselves with the opposite gender. So we should have an unbiased approach to all these aspects. So the concept of gender fostering is that we should actually not medicalize it, we should treat it as a very normal physiology, and it has been actually introduced as a section in the latest ICD classification. So it's no longer considered as a disease also. So it's documented that we have to have an environment which is sensitive to the concerns of the child. So we should not tell them it's a mental health, you should not have it. They are desisting from conversion therapy, because previously when the child was having a different gender of their choice, the parents used to take them to the other doctors or other people or even quacks to change the gender of bringing and want them to bring the change of biological sex. That has actually been told as a wrong thing. So social support and acceptance at all comes through the gender fostering. So this is a new terminology which has come through. I wanted the audience also to understand this basic terminology. So Dr. Pramila ma'am, please highlight the newer concepts in this biological spectrum.
Yeah, thanks Dr. Mohan. So, sorry. So then we have some newer concepts or newer words which are there. One is the gender diverse. That is a blanket term which we use, which is basically to say that people, when their gender identity or the expression does not conform to the norms and the stereotypes as per the expectation. So that is what is called as gender diverse. So people want somebody to behave like a female and that person is not behaving like that. So that is not conforming to the societal norms, but the person is comfortable with that. So this is what we say that they call that as gender diverse. Then transgender, which we normally don't use for children, we use it for adults. And then there is a gender reassignment when we give the hormonal therapy or we do the surgeries and we say gender affirming hormonal therapy, we are giving to the gender which the patient is or the person or the subject is preferring. And then there are surgeries which are done, which is called the gender reassignment surgeries, which the person may opt for, may not opt for. So then we come to the principles of care. So I would like Dr. Ashok also to add here, because he also deals with gender incongruent patients and children as well. So Dr. Ashok, what are your opinions on the principles of the care, what we do for these adolescents or children who come to you?
Yeah, I think the foremost principle of the care is that we should listen to the child, and we should not rush for the diagnosis, or we should not rush for the anything. Just as Dr. Mohan have highlighted, that the gender posting is there. So we should try to understand the child. This is the first and foremost part. Now, once I think there is a reasonably surety about that the child have chosen the gender, then I think the next step is that we need to look into the pubertal staging of the child. Have the child entered into the puberty, or is the child pre-pubertal, or have the child experienced the first sign of the puberty? Because sometimes the diagnosis which was in doubt or the identification which was in doubt reveals itself at the first sign of the puberty. And I think this is beyond that time we should not wait for the further suppression of the puberty, and we can buy some time further by suppressing the puberty preferably with the GnRH analogues which are having minimal side effects. So
thanks, Dr. Ashok. So this is how we go on. We have already discussed about this before also. So we know that the indication for pubertal suppression has to be there. The gender dysphoria has to be severe. Dr. Mohan, would you like to add any point on this?
So we should actually believe the narrative of the child, and we should know the law also. So the background of this discussion is basically we should know what the person will deal in the future. So we have to make, the child has to grow into adult, transition towards that. So that process has to be helped by the pediatrician. And along with pediatricians, we have to have other stakeholders also. So pediatricians are very important cog in that aspect. I am part of the IAP team, so we are actually trying to build that, because I think medical curriculum does not have that in our perspective. It is a very new concept. So I think we are trying to build that in our own ways. So as a community, we should actually try to build the trust with the parents, system, and with the fight society also. So I think that's what, and pediatric endocrinologists or another clinician experienced in the assessment of puberty, because puberty has some stages. So that is built on the SMR, which have got a staging for that. So that also has to be documented precisely. And there is a regimen for hormonal intervention, and includes the individual centers and mental health exert, and also medical risk also. So all this has to be explained beforehand, and we should try to document the options available. So after that, we should divide on the hormones. We don't give them directly sex change or cross-sex hormones. We try to give them pubertal blockers if possible. And later on, once we are monitoring, then only we go for that. So that's what. Next slide.
Yeah.
Carry on.
Yeah, so we, as both of them rightly pointed out, that once we have the full diagnostic criteria and we go on with the puberty blockers, and only later when the child is ready to take a decision, we go for gender affirming hormone therapy, and only after that think about the surgery. But that's initial stages. When we are talking about children and adolescents, it is the puberty blockers which needs to be given if the gender dysphoria is very, very severe and it demands suppression, puberty suppression, and that's the time when we decide it. But it has to be decided in consultation with the parents and the child. That is the most important thing, and everything has to be taken into consideration. So again, it comes to an individualized decision. It's just not a blanket statement. And as Dr. Mohan rightly pointed out, that pediatricians need to be sensitized about it, because the first place place where, or the point of care would be a pediatrician rather than an endocrinologist directly or a pediatric endocrinologist. So pediatricians need to know this so that they can do the timely referral. That's the most important thing. And a mental health professional is a very important part of the team. So when we are talking about this, one more thing which we need to understand, that is just not the puberty blockers, because blocking the puberty is very easy. Therapy is available, we do it. But we have to think about many more things, especially the bone health, because that's the time of puberty when the bone is building up. So we have to see for the bone health, the calcium intake, the vitamin D intake. We have to counsel about that and take care of that, because later on the child should not have problems with that. As well as we have to see about the mental health of the child, how the behavior in the society, especially the school and the friends, that has to be also seen, because that is a very, very important aspect of treatment. And not to forget the metabolic health, because if the puberty is not happening, we are giving blockers, we also have to monitor the metabolic health, including the cholesterol and the glucose values as and when required, and the weight gain, because there may be fat deposition, which may be fat, maybe visceral fat may increase. So all these things also have to be taken into consideration. So Dr. Mohan, would you just let us know a little bit about the consent, assent and the legal age, because that's a very, very important topic.
Yeah, so as we have already discussed so far, we have set the background of it, and we should know there is something as a mindful communication. So it's really impactful communication. This graphic we have prepared just to show you that just like the branches of a tree, we have got that so many branches of the tree, just like that everything is important. So first is the documentation. So we should document that the person is having dysphoria, the person is having some issues, and we should document that there is a change of gender also expressed. We should also document the concerns expressed by the parents. We should document the community aspects also that others people are also telling. So then we should also communicate in the proper way by knowledge of the law and the circumstances which that person is going through. The school has to be involved in the education pattern also. Attentive listening and grasping quick clues. So this is also important. Whenever we have a counseling session, we should spend more time with that person and grasp any clues which can be there. And finally, the language is important. So whenever we address the person, we should always address not by the name, we should try to address by that person's choice, what is the person like to express himself. So that him or herself. So the language is also very much non-affirmative language, very communication with the ease of flow, and we should always keep the person's aspects, what they want to tell us, we should always allow them to speak their mind also. So the standard format is there for these procedures. The Indian government has framed some good website laws, because we should actually enter these in the website for the transgender, or there is a law act for that. We should always put in the registry which is meant for that. There is even the Aadhaar card which is already generated. We can even change that gender, assign later on also with a person's choice. And also there is a legal framework, as you already know, the age group which we have to work on. So already I have not extending it. So Australian other guidelines till 16 years may be accepted, but Indian guidelines are a bit rigid. 18 years or adulthood is what they insist. And all these therapies have to be told them that they have side effects. They are not devoid of side effects. So like bone pain can be there, some other issues can be there, even pregnancy can be caused by all sorts of things. So we should always tell them that these are all side effects which is known to happen. And also they should have a backing of organization. There is ethical committees are there, because some laws require the institutional ethic committee to back them up. So whenever we do some medicine which are not truly guideline based or research based, we should always have the ethical committee to work along with you. We should not work in isolation with that. So I think with this we have to address the last few sections on barriers to care. So what are the barriers to care, ma'am?
So Dr. Ashok, would you first like to comment on the barriers to care, what you see in your setup, because we all work in different type of setups?
Yes, definitely, ma'am. The biggest barrier to care is the general awareness actually. See, the public is the primary care provider. For example, the first contact person of any problem in a child is the pediatrician. So if the pediatrician is not aware about what is the gender fostering and how sensitively to handle the gender of a child, then I think we are failing at the first step. So we need to create the awareness among the pediatricians about that we need to be gender sensitive, and these are some salient points that when we need to take care of the specialized person. So this is the first barrier. After that, the second barrier comes at the level of the society, like at the level of the family. Again, sometimes parents don't accept the fact that the child needs care, and this is something normal but not common. It's normal but not common. And we cannot fit everything into the same frame. So these are the main barriers according to me. I think more can be highlighted by the Mohan or ma'am.
Yeah, thank you, Dr. Ashok. So that's what, as he rightly pointed out, that the limited access to the gender-affirming care, that's the most important barrier what we see, and prejudice and misunderstanding of the caregivers as well, because many times the parents don't understand. There are some children are fortunate enough that their parents are supportive, but many parents are not supportive as well. And the main important thing which we see in our practice is the lack of medical insurance for any of these, because suppose they get any issues or any illness or anything, they will just blame it on the hormone therapy, or even if for adults, for everything, if they are on hormonal therapy, they may not get the insurance clearance or the claim, even for other illnesses if they have. So that's one barrier which we see, especially in our country, which we are trying to, even in Karnataka, we are trying to talk to the government to make these things better for the transgender population, especially the adult population as well. So this is one important barrier which I think needs to be addressed too. And obviously there is no structured training, because if we see our medical schools, now actually the curriculum has been included with the transgender and the gender incongruence information, but till when we did our MBBS, there was nothing like that which we were taught. Now, good enough that the authorities have realized that they need to educate, so that's one thing which is coming up. And legal support is also something which many physicians and caregivers are worried about. So these are all the barriers. So let us see how we can overcome, and what are the other things which we need to look into. Dr. Mohan, would you like to comment on that?
So there's a task force for the gender incongruence, and public health experts have gone through this. So I think ATI, IPATH and all associations are partnering along with the societies. So ESI also plans to come out with their own ways. So public health approaches will be holistic, and all societies should try to deliver the transgender health care, and we should have referral centers where the people know where to go there, access to treatment. So even the agencies should partner with themselves. So we should overcome the barrier by a steady process. We should be having resources, advocacy plans, awareness, education, empowerment, listen to what the person tells, and finally nurture the person, non-judgmentally. So this is all the training measures which we can do. The staff can be sensitized, the competency can be ensured. We should always individualize, should be correct names and pronouns, confidentiality of identity should be ensured, assumptions should be avoided, and finally open-ended questions should be tried to limited. So criteria are also very strict, so we should try to affirm to that. And finally, mindset of authorities. So whatever we do, authorities should accept that person, what they goes through. So we should try to have a straight line rather than zigzag pattern. So now stakeholders have been included along with that in a rainbow pattern, inclusive, accepting, welcoming space. Empty environment is what we want. So evidence of these efforts actually have come out, and actually you can see just outside the room I just saw that there is a gender neutral bathroom also. Even that is also important. Observing all these delicate cues. In Kochi we have Kochi Metro, which is employing largest number of trans people in the society. So we should try to give them opportunities to employ, try to make them more accepting society, give them employment which wherever possible. And we should try to have a neutral uniform, because even Kerala has stood out of that, because schools have also tried to practice, colleges are trying to come out with that. We should have gender neutral uniforms also. So whatever ways possible, we have to do that. So I think I will just go through the key takeaways. So in this discussion, whatever we have tried to give, we have clubbed 2 sessions together because of the time constraints. We have understood the basics of gender. It has actually come out from the binary concept to the fluid concept. And now girls, boys, they are not discriminated, they are just kids. So we should try to be inclusive, refer them timely. So we are not claiming to be totally experts. We may also have some issues. We try to give them more time, and we should come out with the solutions also. So we should try to recognize early, individualize the care, supportive system, education system should be there, and robust coordination is necessary. So last, I think Dr. Pramila can give her takeaways also.
Yeah, thanks, Dr. Mohan. So basically what he has told, that we need to recognize the gender fluidity, and we need to have an unbiased approach. That's the most important thing. And language matters, how we talk. That is also very important. We should not talk like as if something big has happened or this is something wrong which is happening. Like we work with gender incongruence subjects, so we know that it is not something which is abnormal. It is just a normal thing. But what happens that your staff may not be knowing how to talk, what pronouns to use. So we have to little bit educate them about that. So that is also very important aspect, so that they feel comfortable with you. And we have to follow this leader strategy. We have to look, listen and learn from the child's gender identity. We have to see what the child wants, not impress upon what we want, and educate the parents as well as the society. And also we need to see that advocate the rights of the child. So the child should get proper, whatever rights the child has, it should not be denied to the child, and be non-judgmental. That's the most important. We should not make our judgment for that this child belongs to this and this child is doing this. No, we have to be non-judgmental, even the parents as well as the doctors, and let the child take the call. That is the right thing to do. So I think with this we go to the next session. So then we will have the questions at the end of the two. So Dr. Ashok will take us through.
See, whenever we are talking about the transgender care, we need to understand that the disappointment is what is there between reality versus mismatch between the reality versus expectations. So whenever any treatment is started, be it a hormonal therapy, be it a surgical management or whatever, we need to understand the reality, because everybody is different and everybody responds differently with one particular medication. I've seen many prescriptions in which a person is getting Progano, that is the estrogen, to dose of 6 mg per day, 8 mg per day, but the routine physiological dose is 2 to 3 mg per day. It is not going to do any good if we are crossing the normal limit of a prescribed doses, because that particular tissue is not going to respond beyond that time, beyond that particular dose. Now again, sir have asked the question to Dr. Suja that can we do anything for the nipple or areola? See, when we induce puberty normally in a child of the delayed puberty, then the sequential therapy with the estrogen followed by the progesterone provide the best result in terms of the development of the breast. So again, what I want to highlight that there is a particular sequence, particular method, there is certain incubation period, there is certain time duration which is required to get the results. So there is no shortcut into it. So first thing we need to understand that. Now besides that, we need to monitor certain things, because since I am a metabolic physician, so my focus will be more on the metabolic health. So there is one health which is mental health, another dimension is the physical health. So the more focus will be on the physical health. There are certain hormone dependent malignancies which we expect to be slightly more in the transgender person, be it uterine, ovarian cancer and be it breast cancer. Dr. Mohan would like to highlight about should we follow the normal monitoring or screening guidelines, or is there any anomaly from the normal cis male or cis female?
So general guidelines are almost similar, but only thing is that whenever we give some medicine which can produce other condition like GNRS should definitely be monitored. And whatever we do, we should also monitor the DVT or deep vein thrombosis. The breast cancers, the uterine cancers, all these things are known to occur. But the problem lies in which how we do with the screening, because there is no standard methods in which we have to take them forward. Mammograms and all those things can be advocated. So the same risk which the general population carries, an extra bit is there for the cis and trans community. So only point lies when we give hormonal therapy, we should be under monitoring only, and only in the proper person which we choose. We should not give for any person which we have planned.
Now the another aspect is the cosmetology. That can be voice cosmetology to get the desired voice and the removal of the hairs. Now ma'am, would you like to highlight anything on that, the speech therapy or something? Can be?
Yeah, speech therapy is one thing which we have our specialists in our center, like many centers have. So they will help them to modulate the speech like that. So most of them will not need surgeries, especially obviously if we give puberty blockers and all that, then it doesn't happen. But what clients we get mostly come to me after the age of 25 plus. So they do require speech therapy. So we help them out with the speech modulation. But yes, there are surgeries which can be done, but there are very few people who are doing surgeries for speech modulation. So it's not something that they can go anywhere and do it. So this has to be done with caution, only with people who are experienced enough to do these speech modulation surgeries. Talking about the hair, we know we do use finasteride, we do use topical treatment as well, but their laser therapy is one of the things which people go for. What I advise them, not to start it in the beginning. Let the hormones continue for a few months, and after that we tell them to go for laser sittings, because the cost may be huge if they start initially, and the growth may be very fast initially. Over a period of time the growth also comes down, and 6 months down the lane the laser therapy shows a better effect. So those are other options which they can go for. And if the hairs are white, obviously then they can't go for laser, because we have some older people coming to us now at the age of 40 plus, and they have some white hairs, and well, so laser may not work for them. For them, electrolysis and other therapies are the options which we advocate. And actually people are doing the fat surgeries also. They try to do the liposuction, they try to get the fat injected, but these things we don't advocate at the moment, because these things are cosmetic treatment just for cosmesis. But I always tell them that we give hormone therapy for 1.5 years or so, and we mostly see the changes. So they don't mostly need to go for it, but in case they plan to go for it, they should do in consultation with their doctor, and we have to decide that that is safe for them, and then only it has to be done, because those are only cosmetic things.
Thank you. Now I will highlight few more points, and after that I think we can go to the question answer session. Another aspect in the monitoring is that we can divide monitoring in two parts. One is the clinical monitoring. We need to keep a watch on the weight, we need to keep a watch on the blood pressure, and these are the normal physiological parameters which we can study in our routine OPD. Now the next thing is we need to look into the lipids, because hormone therapy can affect the lipid profile. We need to look into the sugars, we need to look into the risk of the DVT, as ma'am have highlighted. So these are the certain points, and again the good lifestyle is also required. That includes the cessation of the smoking, and which is a cardiovascular risk factor. So these are the points, like everything starts with the lifestyle modification, and beyond that I think the routine follow-up with your physician or endocrinologist will help in sorting out the things.
I would like to thank all the speakers for the wonderful session. It was a really informative session, sir. Thank you very much. I request Hema ma'am to felicitate Dr. Ashok K. Rohilla. I request Sanjay sir to felicitate Dr. Pramila Kalra. Again, I request Sanjay sir to felicitate Dr. Mohan T Shenoy.